The moment a woman in 13th century England went into labor, her chances of dying were higher than surviving a battlefield wound, and nobody was coming to save her. This is medieval England. There are no hospitals, no anesthesia, no trained doctors, no understanding of infection. The only person in that room with any knowledge at all is a midwife. A woman who learned her craft by watching other women die and adjusting accordingly. Childbirth in the 1200s was not a medical event. It was a survival event, and for a shocking number of women, it was the last thing they ever did. There was no confirmation, no test, no physician visit. A woman knew she was pregnant when her body told her. Missed cycles, nausea, the slow thickening of her waist. From that moment, life continued exactly as before. Fields still needed working. Fires still needed feeding. Children already born still. A pregnant peasant woman in 13th century England worked until labor began. Not because she wanted to, because stopping meant the family did not eat. The physical demands placed on her body throughout pregnancy were the same demands placed on it every other day: bending, lifting, carrying, grinding grain, hauling water from wells, tending livestock in cold and mud. The diet sustaining her through pregnancy was the same thin diet sustaining everyone else. Pottage, dark bread, whatever could be foraged. Meat was rare. In winter, a pregnant woman survived on stored grain and salted scraps, while her body tried to build another human being from almost nothing. Medieval medicine had a theory for pregnancy rooted in ancient texts passed down through monasteries. The womb was believed to be a vessel governed by humors, blood, phlegm, yellow bile, black bile. An imbalance was the explanation for every complication. The treatment for almost every complication was the same: rest, herbal remedies, and prayer. If things became serious, bloodletting, taking blood from an already weakened pregnant woman in the belief, it would rebalance her internal forces. The knowledge gap between what was believed and what was actually happening inside her body was absolute. When labor began, the midwife was summoned. She was not a licensed professional. She held no qualification. She was a village woman, usually older, experienced from her own pregnancies, and from years of attending the births of neighbors. Her knowledge was entirely practical and entirely oral, passed from woman to woman across generations, with no written record and no mechanism for correcting errors that had been repeated for decades. The best medieval midwives saved lives through accumulated practical wisdom that no physician of the era could match, because no physician of the era ever attended a birth. Male physicians in medieval England did not enter the birthing room. Childbirth was entirely a female domain by both custom and law. The birthing chamber was sealed, windows covered, doors shut, men excluded entirely. The pain of labor was understood as the consequence of Eve's transgression in the Garden of Eden. Women were meant to suffer it. The suffering was not a problem to be solved, it was a debt being paid. So the midwife worked alone, with her hands, her herbal preparations, and whatever the woman's own body would allow. She had no surgical tools beyond the most basic. If labor progressed normally, she guided it. If it did not progress, normally her options narrowed very quickly. The birthing room in a peasant household was the same single room where the family ate and slept. Straw was laid fresh on the floor. The central hearth was built up for warmth. Other women of the village were often present, not as medical assistants, but as witnesses, companions, and practical help. They held the laboring woman upright, supported her weight, brought water, kept the fire going. Laboring women in medieval England most commonly gave birth in a supported squat or kneeling position, sometimes using a birthing stool, a low curved wooden seat with an open center that allowed the midwife to receive the child from below. Lying flat on a bed was not standard practice. That came later, introduced by male physicians who replaced practical wisdom with a position more convenient for the observer. Pain relief did not exist in any effective form. Herbal preparations were used: pennyroyal, mugwort, ergot of rye, in carefully managed doses to strengthen contractions. Some preparations helped, some were actively dangerous. The line between a medicinal dose and a toxic dose of ergot was thin, and the midwife walked it by intuition alone. There was no standardized dosage, there was no chemistry, there was experience, and there was luck, and there was the woman's own body. The laboring woman was expected to endure. She was encouraged, she was held, she was prayed over. The priest was sometimes nearby, not to assist but to be ready. Last rites were not an unusual feature of a medieval birth. They were a practical precaution. Normal labor was dangerous. Complicated labor was catastrophic. A baby presenting feet first gave the midwife almost nothing to work with. She could attempt to turn the child manually, reaching inside the womb to reposition it, without anesthesia, without sterilization, without any understanding of the infection she was introducing with every touch. The attempt itself frequently caused the death it was trying to prevent. Prolonged labor had almost no intervention available. If the child could not be delivered and the mother was dying, the church's position was explicit. The child's soul was the priority. An unbaptized child who died was condemned. If the mother died before the child was delivered, the midwife was instructed to cut the child from the body immediately to allow baptism. The instruction existed in writing in medieval religious texts. It was not theoretical. Postpartum hemorrhage killed women who had survived labor successfully. Herbal preparations that contracted the uterus were the only intervention. When they worked, they worked. When they did not, the woman bled, and the midwife watched and held her hand. Infection killed women in the days following birth. Puerperal fever, childbed fever, swept through a woman who had survived labor and killed her between day 3 and day 10 afterward. It was caused entirely by bacteria introduced during the birth process. Nobody knew this. The fever was attributed to an imbalance of humors. The treatment was rest and herbal teas. It was fatal in a significant percentage of cases, and entirely preventable by the washing of hands, a connection that would not be made for another 600 years. If the birth was successful, the child entered a world that was immediately dangerous. Between a quarter and a third of children born in medieval England did not survive their first year. The causes were infection, cold, malnutrition, accidents in the crowded single-room household, and disease. The newborn was immediately cleaned, wrapped tightly in linen swaddling bands, and baptized as quickly as possible. An unbaptized child who died went to limbo, permanent exclusion from heaven. The priest came before the mother had recovered. Swaddling was universal and considered essential. The belief was that an infant's limbs were soft and unformed and would grow crooked without tight binding. Babies were wrapped from shoulder to toe in strips of linen, arms pinned to their sides, for the first months of life. The practice immobilized the child completely, which had the practical effect of making an infant easier to manage in a household where every adult was needed for labor. Breastfeeding was understood to be important, but was not always possible. A mother weakened by a difficult labor, malnourished throughout pregnancy, sometimes could not produce adequate milk. Peasant families had no alternatives beyond thin gruel and animal milk when available. Medieval women who survived multiple pregnancies carried the physical evidence in their bodies permanently. Skeletal remains from 13th century England show clear markers, stress fractures in the lower spine consistent with repeated pregnancies, the deterioration of hip joints in women who died in their 30s, showing the bone density of women twice their age. Archaeology reads these bodies the same way it reads the worn, flat teeth of peasants who ate grit, filled bread. The physical cost of survival is written in the bone. Women in medieval England had no control over the number of pregnancies they experienced. Contraception existed in the form of herbal preparations, some effective, most not. The church condemned the attempt entirely. A woman who survived to adulthood and was married could expect to be pregnant multiple times throughout her life. Each pregnancy carried the same risks as the last. Each birth was the same gamble. The women who attended births understood this better than anyone. They had watched it repeatedly. They had done everything within the limits of their knowledge and their tools, and they knew exactly where those limits were. They were not ignorant. They were not ignorant. They were constrained by theology, by the exclusion of women from formal medical education, by the complete absence of germ theory, by tools that stopped at the boundary of what hands alone could do. They worked anyway, in smoke, filled rooms with straw on the floor, and a fire built high, and a woman in agony. They worked with everything they had. In a world where bringing a child into it could take you out of it, every woman who survived childbirth in medieval England had beaten odds that would make a modern person's blood run cold. They did it without pain relief, without sterile instruments, without a single piece of knowledge we now consider basic. They did it because there was no other way.